Welcome to the Pain Science Podcast, where we discuss science-backed ways to treat chronic pain. I'm your host, Dr. Joe Tatta, a licensed physical therapist and founder of the Integrative Pain Science Institute, where we train practitioners in whole-person pain care. This podcast also serves as a public health campaign to support those living with chronic pain. This podcast is for informational purposes only and not intended to be a substitute for professional medical advice. Welcome to this week's episode of the Pain Science Podcast. I'm excited that you're here with us this week. Today's topic is how physical therapy became treating physicians in the state of Montana. My guest this week is Dr. Emily Herndon. She is a primary care physical therapist who is the owner of Plains Physical Therapy in Plains, Montana. Emily is also the president of APTA Montana. That's the Montana Physical Therapy Association. And Emily has been a critical leader in this primary care physical therapy movement within physical therapy, and of course, helping physical therapists become treating physicians within the workers' comp system in the state of Montana. We're going to talk about all that and more on today's episode. Before we begin, I'm going to ask you a favor. If you could subscribe to the podcast on your favorite platform, I would appreciate that. It helps us deliver the message further and wider on important topics such as this one, like primary care physical therapy. Okay, without further ado, let's begin and let's meet Dr. Emily Herndon. Hi, Emily. Welcome to the Pain Science Podcast. It's great to have you here this week. I'm excited to talk to you about how physical therapists in Montana became treating physicians.
I am so excited to be here to talk to you about it because it has been just an amazing kind of transformation of really being able to tell the story of how physical therapists just really in Montana quietly became a part of the primary care system. And now we have a law that actually recognizes it just in the workman's compensation space, but still it's huge, and how we can really transform and really not really transform what we do, but be recognized for what we've already been doing for years. So I'm excited to be here.
Thank you. We're going to dig into all of that. I think it was a great introduction, and people heard in the introduction to our start here that you work in rural Montana as a physical therapist, and you've had your own practice there for many years, a very successful practice. You take, as you mentioned, a primary care approach plus an integrative approach. I know you use lots of different interventions that many physical therapists are using. How did that early exposure as a physical therapist in rural Montana start to shape this experience for you?
hmm I mean, I have been working in rural Montana as a business owner and practicing for over 17 years. And really, that was my goal when I set out of school right from the beginning in 2006. This was my goal. In 2008, it became a reality, and serving a community where access to healthcare isn't really theoretical, it's survival and different modes. And luckily in Montana, we've had this direct access state since 1987. So I've worked in this direct access space without any restrictions for nearly my entire career. And so in Montana, the physical therapy clinics are often the most accessible entry point into the healthcare system. And the interesting things is patients as you know, Joe, don't show up with a diagnosis. They just show up with pain, injuries, mobility problems, and functional limitations. And so we spend our time evaluating and diagnosing and within the scope of our practice, ordering, referring, and prescribing based on what we need to do for the patient and what's in front of us. And many of it is not traditional, but in a way that serves the whole person, and that's super important. So, I mean, throughout my career, I was ordering x-rays early, MRIs, CT scans, ultrasounds. I employ 2 therapists that do diagnostic ultrasound imaging because we want to know the path that we need to go to better provide care. And I've even on occasion ordered an echocardiogram because I'm a lymphatic therapist. I want to make sure the heart is healthy to be able to prescribe what I need to do to help them. So it became evident not early on, but later now in my career that I've been working in this primary care space for years and directing care in a way that makes sense for my patients and knowing what I can't treat right from the beginning. And so it's just been an amazing evolution in the last 20 years of my career to see where this is going. And then to turn around and see a law in Montana that really highlights that. It's not scope expansion. It's actually just, in my mind, clarifying what we already do.
It's not a scope expansion. It's really just the law meeting us where our skill set rests naturally.
Correct.
Yeah. So you've had direct access in Montana since 1987. Did I hear that correctly?
Yes.
That's a long time. I mean, in New York, I don't know when we kind of switched over, but we still really don't have full direct access. We have kind of limited direct access, but it didn't start in 1987. Although in New York State, for as long as I can remember, as long as I've been practicing, we could always see a patient once.
Hmm.
And then we obviously would have to refer them out for a prescription or whatever it is. And even in those circumstances, what I really appreciate you saying, when I had my larger, private practice, I was functioning in the same way because people would come to us directly, even if it was just for one visit. But I had the opportunity to evaluate them, screen them, and say, okay, you need physical therapy. All I need is a prescription. Your doctor can quote unquote fax that over. There was days of faxing, or you need to get an X-ray or an MRI, essentially, or something different. So I appreciate the kind of historical context there. I'd like to give people a window, because I know you well, and I know what you've been through in your career. I'd like to give people a window into what rural Montana looks like where you live, just because the word rural, sometimes people think of different things. But can you kind of give us an idea of like, where does this practice sit in the state? And how does that impact not only your patients, but also your ability to practice?
Yeah. So Plains Physical Therapy, which is the business that I own, resides in the town of Plains, Montana, which is on the far western side of the state. So we are 75 miles northwest of Missoula, Montana, 75 miles southwest of Kalispell. So those are your two major metropolitan hubs, which is between 60 and 80,000 people. So now Plains is great because we also have, I'm in private practice, but we have a critical care access hospital there. So I leverage them all the time, which is absolutely fabulous. But the town itself has about 1,100 people. We see probably the physical therapy, our like range probably in the county probably extends to 5,000 people. And the clinic I own and work at, we saw over 700 patients last year in this community. And yeah, they come to us for everything from aches and pains. And it's amazing the number of patients that come to me because maybe they don't see their doctor on a regular basis. They're healthy. And so I have had more than one patient show up and go, Emily, I really don't know if I really don't think you can treat me at all. I don't think this is related to my back pain. But I don't even know where to go or who to ask about what I'm experiencing today. And so can you please just tell me what I needed to do? So I have patients accessing me because they can get in quick. They trust me. They know I know their bodies and what's quote unquote normal for them or slightly abnormal because they're seeing us and where to direct their care. And that's when I really started to understand our primary care space and our role in our community. And so 700 patients in an access, most of them all come to us directly. We do have the traditional referral sources for sure, but we also know like Medicare, assigned plan of care is a referral. And we utilize that all the time. So, and our patients know that and they utilize us in this way also. So most of our patients come to us directly, call and schedule an appointment, and it really just comes down to the insurance sometimes.
Yeah. So small town,
Hmm.
far from any relatively major metropolitan area as far as Montana is concerned. And obviously you're embedded there. You have a positive reputation of helping people and they come back to you because they trust you with making a good decision about triaging them essentially where they need to go, essentially.
Yes.
Yeah. It's such a success story, Emily. Congratulations.
Thank you.
Yeah.
I have an amazing team around me. It makes it easy.
Yeah. Now I know you didn't set out, so you set out to start a practice and build a practice as a
Right.
clinician. I know you
Right.
didn't necessarily set out to go into the legislative piece of things. So bring that into the story here and let us know how that started to develop.
I mean, as I said, my focus was very direct. I am going to go into rural private practice in Western Montana. That was my goal from day one of graduating from school. And I figured advocacy was never in my wheelhouse, politics or leadership, because frankly, I'm in a small town and going to be working in a small town. And I figured that was going to be limited to my patients and my community and nothing else. And then something happened, and it happened to all of us. And that was COVID of 2020. And I found myself, I I shut down my business. I laid off my 8 or 9 employees at the time, and I did it out of my daughter's health. So she is a medically complex child, and I couldn't have her enter the healthcare. When she gets a cold, she ends up in the PICU. So I couldn't have her come into a healthcare system that was collapsing around us. And I was like, you know what? I need to just shut it down. I transferred everything to the critical care access hospital, and the rating was on the wall already. Like, this was early March, and I had patients already canceling, and I'm like, I'm not going to make payroll for for my employees in the next couple of months. And so for the next 3.5 months, I found myself for the first time in my career, as a stay-at-home mom with a kid on kindergarten Zoom, a kid I decided to potty train, and a husband that if he said 5 words, he met his quota for the day, which drove me absolutely bonkers, all of it. But it was the pause in my career that I never knew I needed, that gave me time to sit down, reflect on what we were going on, where the profession was going, what it looked like. And really, it frankly pissed me off. I was like, why am I working in this system that doesn't value our care, doesn't value it in reimbursement? I was looking at 20% decrease in reimbursement in the years that since I opened the business, prior authorizations, more paperwork, all of this stuff. And I was like, what is happening? So what does any APTA member do? They send off an email to their chapter president to complain. Now, I will not complain without solutions, because I don't want to sit there and complain. I'll complain over a drink with somebody and just as a sounding board. But if I'm going to approach somebody, I'm going to come with some solutions. And he says, there's some board openings. I think you need to run. And I was like, well, I'm bored, so I should run. So I said yes. And that was how I started into APTA Montana and this leadership role. And just out of the frustration of what it was, and figuring that me sitting I can't sit on the sidelines anymore. I can complain, but that's not going to change anything. I need to do something, or I need to leave. And I love my profession too much to just leave. So there we go. That's how we started.
Yeah, it's interesting because you and I know each other for a while, and I think you took our nutrition course, and we communicated a bunch, and I was aware of your family, and then I feel like all of a sudden I turn around and you're leading this charge in Montana. I'm like, oh, Emily is now the president, and she's leading this charge, and what's going on? And I was like, okay, I'll watch this play out over a couple of years, and it wasn't a couple of years. It was really super rapid.
Mm-hmm. It's
So
insane.
it's another big success story in your career. Tell us, how you took this obviously big topic, because it really sits under the umbrella, I would imagine, of primary care physical therapy. But you somehow, you and your team there in Montana, distilled it down to workers' comp. So tell us about that connection.
Yeah. So, just fast forward in 2025 legislation. 2023 legislation, we introduced Montana Medicaid reimbursement. It just got tabled in committee and said, we don't want to take it out. And then we actually had a lot of turmoil in hiring lobbyists and really discussing what this problem was we're having, and it focused really on payment, because most of us realize we can't continue to serve our communities, which for me, it's 12% Medicaid, unless I'm being paid and reimbursed at least close to my overhead cost. And what we figured out was we're losing $44 an hour. And that was our main thing. So we realized that our current lobbyist wasn't matching what we needed. And he didn't feel like he was a good match either. So we moved on. And we hired this new guy that is a small business owner, an outfitter, a traditional Montana guy that knows very little about healthcare, but understood business. And so when he looked at our Medicaid reimbursement problem, he said, well, this isn't a healthcare problem. We're like, well, yeah, kind of not. I mean, it's an access problem, He goes, no, no, no. Our legislators don't care about that. They care about money and small businesses. And so he's like, this is a business problem. And then us in the room are like, yes, this is a business problem. It's not a healthcare problem. It's a business problem. So he was sitting at the table during one of our legislative committees and I asked Lorena Pettick Payne, who was a former APTA Montana vice president and former vice president of the Special Interest Group in Occupational Health. She's worked in occupational health her entire career. She's amazing and 40 plus years of experience. So for years, since 1987, we've had direct access. So for over 20 years, she's been arguing with our Department of Labor about direct access because in Montana, the rules were simple. You weren't on the list. You didn't get patients directly. They would make exceptions and all that kind of stuff. But in reality, they said, no, you can't manage that patient. And so I asked her about how's that conversation with Department of Labor going? And she's like, oh, same old stuff. Da, 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 da. They're not letting us gold carding, other, just different solutions. Like, let's trial this. Let's do this. Let's do this. And Scott, our lobbyist, was like, excuse me, what conversations you're having with Department of Labor? And we're like, well, here's the situation. We actually can't see patients directly, even though we can see the rest of the state directly. And Department of Labor isn't coming to us with solutions. And he's like, well, that's not for the Department of Labor to decide. That's for legislators to decide. So we're going to run that bill. And we're like, did you just sign us up for another bill? Huh. I didn't know we could run another bill. So that is how SB 109 got introduced. And in Montana, the legislation was it's a bill that specifically said who is the treating physicians for the workman's compensation space. And it lists all of these different people. And so chiropractors, dentists, PAs, nurse practitioners, MDs, orthopedists, and had all this list. And we just said, just add us. That was the simplest thing of changing legislation, was adding a physical therapist to a already existing bill. So that's how the bill, and the moment we really realized that we actually could make this major change and shift the conversation and our profession in Montana in a way that realizes what we already do. So
There's a critical piece here that I think we should put some attention on, and that's the lobbyist.
Mhm.
Explain to people who are not so well versed on the role of the lobbyist and how they can work with a state association like the Montana Physical Therapy Association, and really what their role is and how they help facilitate the things that we want to see done.
Yeah, I mean, he is our boots on the ground. We hired him because he has all these just different connections and can get his foot in the door to have conversations. He has lots of relationships. That's what he does full time, and it's relationship building. And coming from a person, it actually was more valuable for us to have a non-healthcare lobbyist that could speak simply. And I hate to say that, but sometimes we start talking, he's like, girls, because it was mostly girls of us involved. He's like, girls, I don't know what you're talking about. Dumb it down, because no one else is going to know what to talk about. And we're like, okay. So when we put a white paper, right? We
Every
put a
time
white paper.
purpose, I'm like, your language is way too high. Your patients don't understand it. Your referral
Yeah.
sources don't understand it. And the public definitely doesn't understand it. So I really appreciate that perspective.
Yeah, he was phenomenal at that. And we produced a white paper. I don't remember which bills, because actually we ran 4 bills in the end, which was insanity. We don't recommend 4 bills, although we are looking at 2027 and running 5 bills. Oh, weird insanity. But anyway, we were producing this white paper, and he's like, wait, again, ladies, wasn't the point this? And we're like, yeah. And then he's like, that isn't mentioned at all in here. Redo this. And we're like, oh, thanks. So like he was always our good touch point of what the pulse of our legislators know and don't know. And he was also really good at the touch point of understanding what our opposition knew and didn't know. So we have coming up in 2027 a animal physical therapy bill that's being put up by one of our members that's actively engaged. And we're already having conversations with like veterinarian associations and making sure that when we put a bill up, we already know what the number is. We already know what our score is. We already know we're going to pass through the committee, hopefully with no opposition. And so we, he is just instrumental in making sure those bills are clean coming in and they're easy to pass, because when Montana legislation runs, it has 1,600 bills in 4 months that they've got to get through.
Yeah.
So
So what was the opposition to this bill?
we did have opposition. And so we had independent insurers, trial lawyers, although weirdly enough, I think they may have been talking in our favor. I'm not really sure. They kind of walk around in circles for a while, opposing. I'm so sorry if I do not offend any lawyers here in this room or listening. Montana Physicians Association, and like a few others. And their opposition was kind of what you would expect, generally speaking. They said, well, PTs, they can't diagnose, they can't order an image, they can't refer, they can't manage complex medical conditions. And the most insulting is the paperwork is complicated.
Yeah, of course.
I mean,
Thank you very much for letting me know about that.
yeah, thanks. Like, no, we don't work with complicated paperwork at
Yeah,
all.
so like paperwork is interesting, but I want to kind of bring this back to an important topic, and that's our ability to serve the public. Saying that, and if I heard you correctly, physical therapists don't manage complex patients,
Yeah, that's what they told us.
right? And so to kind of clarify that, meaning patients have multiple comorbidities,
Hmm.
which makes their presentation and their rehabilitation more complicated,
Correct. That's
right?
what they told.
Uh, what we do as physical therapists really is simplify the complexity for the medical system for the patient in some way.
Correct.
Yeah. And
And
diagnosis is within our scope. If certain state practices would open it up or state boards would open it up, is diagnosis within the scope in Montana?
um yes and no. It's vague. So
Or
Montana,
is it now within the scope now that you're considered physicians under workers' comp?
under the Physicians and Workmen's Comp, if you look under their laws, it is, because that was what was required of us. So yes, it is underneath this new law, but not explicit in our Practice Act, but was implied in our Practice Act enough, because we presented our Practice Act and said, this is what we do already. And this is what it is. This fits the language, even if it didn't say diagnose. It still fit the language of, yes, we do diagnose and we do evaluate.
Right.
So
Evaluate, assess, differentially diagnose. They're somewhat similar terms.
absolutely.
Yeah.
And you'll be happy to know, Joe, that we actually have mental health in our scope of practice. It's actually spelled out in
Yeah.
Montana, which is
I
pretty unique.
shared a slide at CSM about that. I listed this. I think there's about 10 practice act that specifically have mental health in it for physical therapists, meaning the Physical Therapy Practice Act specifically mentions mental health. I know Montana is one of them. And that was
Mhm,
there before you made any
mhm.
changes.
Yes.
Yeah.
So we didn't make any scope changes in 2025. We're going to do that in 2027, because I personally feel like, and our membership feels like, it needs to be explicit.
Hmm.
Because if we're going to look at being in these spaces and own these spaces, I'm really sick of having arguments with insurance companies and vertical hospital system that says, well, it doesn't say that explicitly. And I'm like,
Yeah.
fine, let's change it.
So I'd
So,
like to, if we can look into the future, I want to talk about what those potential scope changes might be. But before we do that, I just want to clarify. So this bill passes through the Montana legislator, and now physical therapists are designated as physicians in the workers' comp system.
mhm.
Doesn't necessarily change their scope, doesn't necessarily change the physical therapist scope, but what does it allow, enable, or facilitate physical therapists to now do, which they didn't have, which they weren't doing previously?
So a couple different things it allows us really to do, which was just which even puts more onerous on the treating physician. So when they come to us, we can decide if they go to work, what are the restrictions on their ability to go to work, what are their work duties. So we can do that a full assessment and make those recommendations. We can then refer them. We can order imaging, which we do, and we can refer them to other providers. That can be a physician, that can be an orthopedist, that can be a chiropractor, that can be anyone within the system, that can be mental health workers. Everybody. We can refer them out once we there are once we take over that role. What I didn't realize until someone pointed out well over halfway through legislation is that actually came with a payment increase.
Mm.
So that was kind of a nice added bonus of, wait, here is where you go. When they access us from a referral, you get paid 90%. When they access us directly and we're considered that first point of contact, we're considered at 100% reimbursement rate. If we are if they're off so many days, and it kind of varies, the rules and regulations around it and varies, but if they designate us as the treating physician for their case, the main patient, managing the imaging, managing this, and these entry points in, we get 110% of the reimbursement rate. So it kind of depends on how they access us. If it's through a referral, then we are that sub-level auxiliary additional provider, or if they're direct access, or we become their quarterback, as one of my friends always likes to put it.
Wow.
So those are the different levels.
Right. So you got an increase in reimbursement essentially,
Mhm.
which is
Yeah.
which is a tremendous win. I'm just curious, in your practice, what percent of your patients are workers' compensation?
Less than 5, to be
That's
honest.
yeah.
Yeah.
Yeah. And I think
Um,
it varies from practice to practice depending on where the practice is and how people work and things like that. But for some practices, it can be quite significant.
Yes. So one of my classmates in physical therapy school called me up soon after that passed, and it was starting to become active October 1st of 2025. And she's like, "Wait, Emily, let me understand this bill a little bit more." And she's like, "Because I'm working as a direct to employer space. So I'm working in their wellness already. And so I coordinate with these employers and I do this. But could this mean that if their worker gets injured, can I take over that and triage?" And I'm like, "Yes, you can triage. You can determine, do they need care or do they need an ice pack? Right? Is it a reportable injury? So we can decide that too. She can decide that in that space. Is this something that definitely needs treatment beyond an ice pack or a band aid, or what that looks like? And then it opens up the workman's comp space. She's like, "Oh my gosh, this just rewrote my direct to employer like conversation." So she was beyond excited about having this opportunity to serve her membership essentially, and open up it in different ways. So we're seeing what's happening organically in the space of how people are transforming their own practices and how patients are utilizing it. And we're working very closely with Department of Labor and our Montana State Fund, which is our largest insurers, our independent insurers association we're working with. We're making sure we show up to their conferences to have these discussions. This is what we do. This is how we do it. Please tell us if you're having problems. Because we're still getting pushback from those managers in there and saying, no, you can't go to a PT first. And so we're having to work with these conversations within those systems that says, actually, yeah, that patient can. And this is why they should. And we can do this well, and we can do this ethically, and we can do this in benefit of both the employee, the insurance, and us, that works better for better healthcare. So we're coming upon those barriers we knew would happen. And that'll continue to evolve, but the future I think is really bright.
This is the way we should be practicing
Yes.
in every state,
Yes.
in every
Period.
district, in every
Yes.
jurisdiction.
Yes. And I mean, my charge for the primary care is simple. Evaluate, diagnose, order, refer, and prescribe. We must have that in every practice act in every state across the nation to actually own what we do. My personal belief is that this is not like the primary care specialty. What I do is not something special. It's not, in my opinion, not a certification, not a new model, not a new subspecialty. It is literally the hub of what every PT does. We just don't acknowledge it, unfortunately. We don't have the language around it. We don't have the acknowledgement around it, but every student does this already. Like they graduate evaluating, diagnosing, order, refer, and prescribe. Now, I know some people like prescribe, they think medications. I'm like, no, we prescribe home exercise programs. We prescribe load. We do this already. We just don't call it that, which is doing, in my opinion, a disservice when we don't own what we already do.
Do you think there's space for us to work into prescribing certain classes of medication? Like,
This is definitely my opinion. So people will argue with me. I think it's going to. I would love to see it in 20 and within the 20 years that I plan on working within the profession. That I would love to see that because I think we can do it. I think we can do it well. I think we can do it smartly. Do we need lots of training around it? Yes. I believe the only way you're going to do that is have a license endorsement to be able to do it. Do you have to have, again, the training and the education? It's going to be an advanced certification or licensure that allows us to. But I think we're doing our patients a disservice if we can't prescribe simple medications that have to do with musculoskeletal system.
it's another roadblock.
Yeah, it is.
Yeah. I mean, when you say a lot of education, I kind of want to put my finger on that for a moment.
Go for it.
I did have, it's a while back now, but I did interview a physical therapist from the UK. Just for some contrast, in the UK, they have either a bachelor's or a master's. In the US, we have a doctorate. Not that their education is better or worse, but they can take a course. I think it's about approximately 3 months, probably about equivalent to a 3-credit semester course.
Mhm.
And then they can sit and become licensed to prescribe not just pain medications, but at all classes of medications. Now, they're not using all classes because most of them are coming probably somewhere in the musculoskeletal range, but you can start to see, depending if you're working in women's health or you're working in neuro PT or pediatrics, that may change. Although I agree with you, I think, I believe what we're seeing happening throughout the United States is how can we make neuromusculoskeletal care more efficient and more affordable? And we're that solution.
I 100% agree. And I do like your context of saying all medications. And I think like that 3-month course is. I think that the 3-month course may be that solution later down the line to have that conversation and then knowing all classes of medication and being tested on all classes of medication. I mean, I personally would refer to my pharmacist saying, hey, I'm looking at this patient. This is what I want to prescribe. Tell me, like, this is your patient too. Where are my red flags? Where are my pitfalls? I think the biggest barriers for our own profession is our own kind. And I think it's people that have been, and I mean, I've been practicing for 20 years now, and a newer person may feel more comfortable coming into this space. And I feel like sometimes the people that have been working in a very subspecialty area and very niche, that would scare the heck out of them. And they don't realize that maybe some of us feel very more comfortable in that space. So it'll be a really interesting progression, but I would 100% love to see it and love to see where that evolves in the next, hopefully less than 20 years.
Yeah. Well, I don't know I don't know what's happening in every DPT program, but back in 1995, way in the Wayback Machine, when I had a bachelor's in physical therapy before I went back for my DPT, we had a 2-credit pharmacology course in the physical therapy program.
Yeah, right?
We
I
also,
had one.
we also had a 2-credit course on psychology of the disabled as well. Now that we have somehow morphed that into psychologically informed care, et cetera, with all these terms. But all this stuff is within our reach. All this is within our scope. All this is within our ability to help people on, kind of this broader level. So I guess the term we're talking about is modernizing the Physical Therapy Practice Act. Is that correct?
I mean, that's where we in Montana and our legislative committee is looking at is very much modernizing our practice act to reflect that. And so that we have those opportunities in the future. As I stated before, our practice act is gray and vague, which is great in a way that allowed us to open up SB 109 and the workman's comp treating physician, allowed us to own it. But then I feel like even our practice act is amazing it is to get this win and designated as a treating physician still needs clarification. because it's what we stand on. And especially in Montana, when we look in a legislative, it's citizen legislative driven, and it makes it in simple language that makes everyone understand that we can evaluate, we can diagnose, we can order, we can refer, and we can prescribe, and just spells it out in a simple manner. We in 2024, we had this major gray area in Montana on imaging. I had actually been ordering imaging when it was gray. I didn't even think about it. I read the Practice Act. I'm like, well, this is explicit. This makes sense. I should be able to do it. And no one bothered me on it. But we realized that some of the other states, when someone would just ask the question, they had roadblocks and they can't order an image, and there's laws against this. And we came at it as an association saying, we didn't actually clarify this and make this part of our language. And so we ended up going to the licensing board and asking them to confirm this. Now, once we've had it confirmed, we asked again to put in rules. Well, rulemaking in Montana takes forever. So it's been almost 2 years and it still isn't sitting in a rule. Maybe this year. Anyway, but I had these emails that I PDF'd out. And so I have these physical therapists going, hey, we want to integrate this in our hospital system. Where's the rule? And I was like, it doesn't exist. Here's all the documentation. And I've been amazed at the number of physical therapists that have gone to their hospital systems, gotten this in place. But they still have pushback that says it doesn't say order in your Practice Act. And that is what we continuously get. So that's the biggest barrier, is someone just reading it and making a decision. Luckily, those physical therapists have been very successful. The 3 that I've worked with in the state of Montana, working in different hospital systems, they're able to order imaging within their system, which is amazing, based on literally some saved PDF emails and explaining what they mean, explaining how this is going to help, how this integrates care, how this provides care that is faster, more efficient, and it greases everything in a way that provides a patient what they need.
Here's the biggest challenge that our profession is facing, and it's how do we all align throughout every state and nationally so that we have the same message that physical therapists can function as primary care providers for neuromusculoskeletal conditions. You've been very successful in Montana. How do we get an aligned message, a through line through our national association, through every state association, so that we can change legislation, so that we can increase access to physical therapy services, and of course, increase payment to physical therapy services?
For me, as I said, my charge with every state would be to put those 5 words: evaluate, diagnose, order, refer, and prescribe, in every Practice Act. And then having all of the research, research, backing, understanding, plain language, because I bless us as healthcare providers, but we shouldn't have 52 words to explain what we're doing. We need it to have simple language that anybody that can pick up can understand what we do, and then also own it as an entire profession and not as a subspecialty. Primary care physical therapy, in my opinion, is never a subspecialty. As I said, in my opinion, other people will tell me differently, and that's okay. I'm up for a good conversation. But I think us as an association at large, nationally and independently, needs to have deep conversations on what we do and who we are, because we do that really badly, in my opinion, as physical therapists. Nurses, they're nurses. I'm a nurse. They own that. They know, everyone knows what nurses is, and they own that to their entire lifetime. I found that physical therapists don't always own that, and that we're not just rehab providers. We're not just this. We're not just this. But even our specialties, like our pelvic health specialties, they're amazingly specialized, but they still do those 5 things every single time they see a patient. And like, I work in pelvic health. I work in lymphatics. Work in pediatrics. I work in everything because, I'm in rural Montana. And I triage even to my own specialties. I'm like, hey, we're not progressing like I think. I think I'm missing something. This isn't what I do primarily. So I'm going to send you down to one of my colleagues in Missoula or Kalispell and have them evaluate you and then tell us our next steps because I feel like that can be provided better care. So, but again, those other specialties are still doing those 5 things. So I think we need to own our base as a profession and really have those hard conversations on what our base is. And also acknowledging that our students graduate with that same base, that they can enter into that system exactly as that. And that's a lot to ask because we got a lot of ideas and there are a lot of great ideas, but where can we agree and have research to support that to make it change in every practice act? There we go. There's my large monologue.
If I'm hearing you correctly, as physical therapists, we need to develop a clear and concise message about what we do or the value we deliver as a profession. We need to have 5 words in every state practice act. Can you repeat those 5 words for us?
Evaluate, diagnose, order, refer, and prescribe.
We have to train our students to intentionally do this.
Correct.
And I would potentially add to that, we need to train our educators that they need to develop the language to train the students so that when they come out of school, even if they're in an environment where this is not necessarily explicitly being done, they still know that that's where they could rise to if given the appropriate resources.
Correct.
Yeah.
Yeah.
A beautiful vision for the profession, right?
I think so.
Yeah.
And
And
I hear that you think I'm gleaming you agree in a lot of different ways.
I agree. I think the 5 words are really key because I agree with you. These are really complex topics. And I can only imagine, I don't have the experience you have, but when you come and you're talking to legislators directly like this in a really intimate way and you're at the table and things are about to happen, you have to be able to clarify what it is that we do, who we serve, why it's important, and what the things are that we provide. And those 5 things obviously make perfect sense within the neuromusculoskeletal realm.
Absolutely. We need 5 words. Evaluate, diagnose, order, refer, and prescribe.
So when you were faced with opposition from other groups, what was your response to them?
So we tackled the diagnosis first because that was where we knew that our profession was weak on and our physicians didn't figure we could diagnose. And so I brought up with me into committee the research paper that looked at clinical accuracy of diagnosis compared to an MRI. And we passed that out to the committee and I said, turn to page 3 and on the top right, look at that table. And you will see that the diagnostic accuracy of a physical therapist compared to an MRI. So if I think it's a supraspinatus tear of the rotator cuff, how accurate am I? Well, orthopedic surgeons are almost 80% accurate. PTs, 75% accurate. Family care physicians, 42% accurate. Emergency physicians, 41% accurate. PAs, 29, and nurse practitioners, 10. Now, I'm not going to throw the rest of my medical team under the bus here. I'm just saying physical therapists can diagnose, and we do it really, really well. Yes, we order imaging. I've ordered x-rays, I've ordered MRIs and echocardiograms. And yes, complex medical conditions, we do that. And so they asked me another follow-up question. They're like, Emily, can you walk me through a low back eval? And I was like, okay, let's talk about that. Okay, we'll take vitals. We'll do a neuroscan, deep tendon reflexes, myotone, sensation, because we want to make sure all those nerves are working. And then I'm going to really stop there because I could spend the next hour talking about what we do and lots of different nuances of it. But what I'm going to tell you right now is not only can I do an exam as appropriate for physical therapy, but I also know even better what I can't treat. So I'm going to use these 3 examples, which these patients gave me permission to use, and tell you about 3 of my patients recently. And that was within the week of testimony. I had an 82-year-old lady come in. She tripped over her bike in her husband's basement. And she walked in and I knew this patient. I looked at her and I'm like, where's your husband? Is he in the parking lot? And she's like, oh no, he went to run some errands. I'm like, well, I guess I'll do an exam because really I'm going to send her to the emergency room because it's 6:00 and I was worried about a pelvic fracture. I was wrong. It wasn't a pelvic fracture. It was a T11 compression fracture, but I sent her to the emergency room, which she needed care. Another patient walked in and she's also in her 80s. And she's like, Emily, I got up this morning and my foot is black and blue and I don't know why. I know she has no sensation in her feet and she has severe neuropathy. So I'm like, well, let me take a look. Well, she walked in. So I'm going to not send her to the emergency room. I'm going to send her to the urgent care. It was luckily a blood vessel that had broke and not a fracture. So they took appropriate x-ray imaging. I had to send her that way because really she's Medicare and it's harder for me to get an image myself. Then the third patient walked in and he has bilateral lower extremity swelling that blew up 2 days ago. I also sent to the urgent care. I figured they'd triage from there. But not only do physical therapists diagnose well and evaluate well, but we know what we can't treat. And we appropriately respond every single time. And the looks on their faces when I'm like describing these patients are like, oh, okay, you can do that. So that was just huge testimony in a way that made sense to these legislators that this is what we do on a regular basis. And to have those 3 examples within the last week, I felt was really helpful.
I love that because you're shaping someone's perception about what we do and what our practice looks like
Mhm.
versus the perception. If you go online and Google physical therapy and you click on images, you will see people in blue scrubs sitting on a ball or holding a weight in their arm. And obviously we use some of those things sometimes, but the perception of what we're able to do, what we're educated to do, what we're skilled to do, what we're competent to do is we have, and this is on me and you and all of us as PTs, we have significant amount of work to educate stakeholders and patients about how important our role is in our communities, essentially.
Yes. And how it isn't just let's move this muscle and let's lift this weight, that it is vitals, vitals. Vitals are vital. Differential diagnosis, red flags matter. All of that stuff that we're trained in, that they don't realize what we do in the background.
Yeah.
And as I always like, and you work in this space too, is like, Emily, you're more than my physical therapist. And I'm like, yeah, I am. And they're like, how? And I'll have these nuanced discussions on uh, just different ways that we approach care and understanding and being able to like know what, gosh, these symptoms aren't adding up anymore. Like I have a more serious concern on my patient's heart and what's the fatigue, what's the decline in function all of a sudden. And I've got a 92-year-old with a heart history. And luckily, we got her in the cardiologist that week. She was scheduled and had a pacemaker placed 10 days later because I sat there and went, wait, something's changed. And it's not physical therapy related, and having that conversation with her family to make a big difference. Those are what we do every day. We just don't acknowledge it. I mean, there's always the conversation with legislators or physicians, you're going to miss cancer. And I'm like, no, we're not. We're going to find what isn't working. And if we're a good PT, which we all should be, we should know when to stop therapy and go, something's wrong. I need someone else to look at it. Because in my career, I've been the first one to raise red flags against 5 different diagnoses on cancer. Like, wait, we have a problem here. And I really think this has nothing to do with what's going on. Let's do this. And we don't talk about that enough, frankly. We talk about, you know, improving their knee range of motion, which is great. Absolutely. They need to go up and down stairs. They need to pick up their grandkids. They get in and out of car. Those are all important things, but we don't talk about the other stories that actually I think are more impactful on a person's health and well-being that has nothing to do with what we do as a physical therapist.
You gave us a good lens into what your practice looks like as a primary care physical therapist working in Montana. What are some of the other practice settings look like that are, approaching primary care physical therapy in Montana? Because it can vary, right?
It can vary. I mean, we've got examples of like physical therapists embedded in emergency rooms. We have that in some of our major metropolitan areas. So we're seeing that. Our direct to employer spaces, there's tons of opportunities. As I said, my colleague who works in the wellness space, because she was done doing the insurance grind and she found this opportunity to work directly with employers and how that's integrated with workman's comp. We have a fascinating model and that we are really trying to encourage in Montana and trying to find ways to incorporate this, but like urgent walk-in physical therapy clinics, standalone. That's all they do is they're available and open. Now we do have restrictions on the Medicaid and the insurance. So trying to find different ways to avoid having the insurance loop jumps through hoops, but allowing like our patients with Medicaid to access us. Because we know with our patients with Medicaid is they're working jobs where they may not know their schedule until Sunday night for the rest of the week. So forget about scheduling an appointment because I'm probably going to cancel it. We also know that a lot of our Montana is full of small businesses. Actually, 49% of our PTs actually work in small businesses just like mine. Amazing, like statistic. And so small businesses are not constrained to normal work hours. They probably don't have a lunch. They probably can't go in. So these urgent walk-in clinics have been essential within our communities, and some of them are metropolitan areas are starting to thrive. So we actually put it out for the state of Montana with the Rural Transformation Program to actually facilitate this model and to encourage this model in rural clinics like mine. And that's still in the process, but we put an RFI back in August to look specifically at encouraging models and then being put research around it to say, yes, this saved us money. Yes, this did this. So we changed the model years ago to you don't go to the emergency room for everything. You go to urgent care so for us, it's like when you're sick, see an MD. When you're hurt, see a PT. I know that's simple, and it's not. It's too simple. And I know PTs will be like, but we do more than just hurt. We do, but it resonates with the community and resonates with like, whoa, I go to my back pain. I'm going to walk into that urgent care clinic today because I have time today. I have an afternoon. I can take some time off and do that. And so that's the model we'd like to change in Montana and have that opportunity to do this in rural clinics and actually look to see if we can do this. But that's also going to take time and money because personally, for me to run a successful rural clinic, which sees 68% of our patients are Medicare, Medicaid, and VA, which is our lowest paying providers in the state of Montana, I can't have a therapist just sitting around waiting for patients to walk in without some kind of financial support or stability. So we're looking at those, partnering with concierge medicine and physicians group to serve their members. So concierge health is existing. So we know that there's some physical therapist clinics that are actually partnering with these concierge medicine. And so they can offer their members physical therapy visits at a significant discount with this group that they're partnering with. So we're seeing that, sports physicals, we had confirmed that PTs are doing sports physicals in Montana. That's not unusual in any other states, but also owning that space that we do medical screening. The number of physical therapists that told me when we put out an FAQ to kind of like get the sense that we're missing anything on sports physicals, one's like, we're not allowed to do medical screenings. I don't know why we'd ever do that. I'm like, I'm sorry. That's what you do every day. We medically screen every single day. And if we're not doing it, please leave the profession. I'm sorry. That's my soapbox. But if we're not doing this, we're not doing good care. And yeah, so those are the spaces that Montana is being really interesting on. And then I'm seeing these emerging practices that are just phenomenally trying to solve healthcare problems, which is access and treating patients as a whole person and how we can facilitate that and be the arm of the healthcare shortage that exists in the entire state and pretty much across the nation. So it's been really fun to watch our members really change how they do things and highlight what they're doing and cheer them on and figure out ways to support them.
Dr. Emily Herndon, I am so grateful that you are leading the charge in Montana. And I know you've started to share all the lessons that you've learned at national conferences like Combined Sections Meeting through the American Physical Therapy Association, and you've shared it with other of our colleagues in lots of different ways. So I'm grateful you're here. I'm grateful you're leading the charge. I feel really confident and comfortable with you leading that charge. I know that this is going to continue. So thank you for joining us this week and sharing your wisdom and your knowledge and your experience in this area. I'm sure people are going to want to know how they can reach out to you or learn more or follow the work. How can they reach out to you and stay connected?
Simply, LinkedIn is where I exist more professionally. If you want to see cute pictures of my children, Facebook's the other place that I frequently hang out. I'm also on Instagram, but I don't even look at that. So feel free to direct message me on any of those platforms easily enough. My website for my business is plainsphysicaltherapy.com. And follow APTA Montana on any of those social media platforms, and we can find out what our association is doing in our state. And those are lots of areas.
We'll, of course, include those links on the website at the Integrative Pain Science Institute. If you're interested in reaching out, you can reach out to Emily directly at her practice, Plains Physical Therapy in Montana. You can find her professionally on LinkedIn just by going to LinkedIn and typing Emily Herndon, PT, TPT, and you can connect with her around everything that she's doing with regard to primary care physical therapy in Montana and our greater profession. I want to thank all of you for joining us this week. If you feel motivated and moved by this topic, which I know you are, please make sure to follow the podcast so that we can send you updates on what's happening in this area as well as others, and make sure to share this with your friends and colleagues. I'm Dr. Joe Tatta. It was great seeing you this week. We'll see you next week. Thank you for listening to the Pain Science Education Podcast. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates and learn about our continuing education courses. If you enjoyed this episode, leave us a review on your favorite podcast platform and share this episode with your friends. Please join us next week as we share more science-backed solutions for treating and reversing chronic and persistent pain.